So we'll start off with a very brief embryology and anatomy of the facial nerve. So the facial nerve is derived from the second branchial arch, and it supplies the muscles which are all derived from the second arch, the muscles of the facial expression, the posterior belly of digastric, the stylohyoid, and the stapedius muscle. It develops during the first 3 months of fetal life, and it is fully developed by 4 years. So what is different between the pediatric and adult facial nerve is of importance to us. We'll come to that. So you all know that the facial nerve nucleus lies in the pons, and from the pons, it goes out, it goes into the cranium. It enters into the internal auditory meatus. So here you will see. So this is the facial nerve nucleus in the pons. It lies very close to the abducent nerve nucleus in the pons itself. And during development, what happens is as the bronze increases in size, the facial nerve nucleus, it takes a turn around the abducent nerve nucleus. So what is the importance of this whirling around the abducent nerve nucleus? This is called the the neurobiotaxis, and any lesion which involves the nuclear lesion which involves the sixth and the seventh nerve, you can infer that has been some nuclear problems if both the nerves are involved together. So coming out of the pons, it enters into the CP angle and it enters the internal auditory meatus, the porus of the internal auditory meatus. In the internal auditory canal, at the fundus, it leaves the canal and it enters into the middle ear, which forms the geniculate ganglion. So the first branch which arises is the greater superficial petrosal nerve. This greater superficial petrosal nerve meets the deep petrosal nerve and it supplies the lacrimal gland after synapsing in the pterygopalatine ganglion. Now, this facial nerve takes a turn at the geniculate ganglion, which is the first genu, and it enters the middle ear. It has a tympanic segment, a second genu, and then it has a vertical segment. This all you know. It exits the stylomastoid foramen and gives a chorda tympani before exiting the stylomastoid foramen. Once it exits the stylomastoid foramen, it gives off the facial nerve trunk. It forms the facial nerve trunk, which gives off the peripheral branches. So these are the temporal, zygomatic, buccal, and the mandibular branches. The chorda tympani nerve, it joins the lingual nerve and it supplies the submandibular, the sublingual, and the submandibular glands. So this is what an overview of the anatomy of the facial nerve is. So what is the difference between the adult and a pediatric facial nerve? In case of a child, mastoid process is not well developed. The mastoid process develops only after 2 years of age, and has an incomplete tympanic ring. The chorda tympani may exit through the stylomastoid foramen with the main trunk in the neonate. Secondly, the second genu of the facial nerve, it is more acute and it is more lateral. The nerve trunk on exit from the stylomastoid foramen, it is more anterior and it is lateral. The marginal mandibular nerve lies very superficial at the angle of the mandible. So what are its clinical implications? As there is an absent mastoid process and an incomplete tympanic ring, the facial nerve lies very superficial. So whenever we are planning to do a mastoidectomy in a child less than 2 years of age, we make the post-oral incision a bit more horizontal. So this is important, very important. Secondly, when we are drilling, we should remember that the second genu of the facial nerve, which is more acute, it is more prone to injury since it lies more lateral. What is the etiology of a facial palsy in children? It can be divided into peripheral lesion or a central lesion. So central lesions are those when there is damage above the facial nucleus between the cortex. So when you see between the cortex and the pons, whenever there is a damage, it will lead to a central facial paralysis. What is the difference between a central and a peripheral lesion, which can also be said as an upper motor neuron or a lower motor neuron lesion? The upper motor neuron palsy, that is what happens is the upper part of the face is spared because the forehead has a bilateral innervation. It has innervation from both the cortices. So the upper part of the face is spared. The contralateral lower half of the face is involved, and often what we see is ipsilateral hemiparesis. On the other hand, in case of a lower motor neuron paralysis, there is involvement of the ipsilateral upper as well as the lower half of the face. So this is how do you differentiate between a central and a peripheral facial palsy. Further division, it can be congenital, it can be perinatal, or it can be acquired palsy. Now coming on to causes of congenital. Congenital, when the child comes out of the mother's womb, you might see a facial palsy on the face of a child. So what can be the causes? It could be traumatic, it could be syndromic, it could be non-syndromic, or it could be genetic. In 50% cases, the cause is not known, and these are classified as Bell's palsy. The acquired causes include infectious, neoplastic, inflammatory, and traumatic causes. So coming on to each of these causes, first is a congenital facial palsy. Congenital facial palsy, it can be because of some developmental defects, that is intrauterine defects, or it could be birth trauma when it is aptly called the perinatally acquired facial palsy. So how do you differentiate between the two? When the child is born, he has a facial palsy. How do we know that the child has a congenital facial palsy or it is a perinatally acquired, that is during birth? There are certain features. In case it is a perinatal trauma, what we see is signs of other injuries. The child may have facial edema. He could have bruising, ecchymosis at the mastoid and or the face. In case it is a congenital palsy, the patient will have involvement of other cranial nerves, or he could have associated craniofacial anomalies. Perinatal trauma risk factors are prematurity, birth weight when it is more than 3.5 kilograms. This is a forceps delivery, it is prolonged labor or maternal primiparity. What is the cause for a perinatal trauma? Why does a facial nerve get traumatized during delivery? Firstly, the bone of the mastoid process of an infant or a neonate is diploic. It is very soft. Then there is the bone covering the facial nerve is papery thin. The marginal mandibular nerve lies in a very superficial position over the mandible, and the pressure of the mother's sacrum on the infant facial nerve can cause facial nerve palsy. Coming on to congenital causes. Congenital causes like congenital pseudobulbar palsy. So whenever you see a child, a neonate, a newborn with facial palsy with other problems, other neurological disorders like dysphagia, feeding difficulties, always suspect some congenital causes. One is congenital pseudobulbar palsy. It involves facial palsy, dysphagia, and feeding difficulties. Arnold-Chiari malformation. It is a name given to a group of deformities of the posterior fossa, ranging from cerebellar herniation to absence of cerebellum. And the child may have vertigo, hearing loss, cerebellar signs, and lower cranial nerve palsies. Hereditary myopathies like myotonic dystrophy and myasthenia gravis. Asymmetric crying faces is an entity which is less known, and it is labeled as facial nerve palsy. But in this, it's an uncommon condition. It is caused by congenital hypoplasia or agenesis of the depressor anguli oris on one side. So this is evident only when the child cries. This lesion, this asymmetric crying faces, the child may have some lesion in the brainstem, and it is associated with serious head and neck, musculoskeletal, respiratory, CNS, or genitourinary anomalies. Chart syndrome. So Chart syndrome, this is a syndrome which includes coloboma of the iris, heart problems, corneal atresia, renal diseases, genitourinary diseases, retarded development, and ear anomalies. So this child with coloboma and facial palsy, this can be labeled as a Chart syndrome. And what commonly we see is feeding difficulties. So not all cases of Chart syndrome have facial palsy. Some can have external auditory, the pinna abnormality. So facial palsy is seen in approximately 38% of kids with Chart syndrome. Mobius syndrome. So this has a varied presentation. Yeah, the child may have isolated unilateral facial palsy, or he may have bilateral absence of both the 6th and the 7th nerve function. 9th, 10th, and 12th may also get affected, and this is because of hypoplasia of the motor nuclei of the cranial nerves caused by hypoxic ischemic encephalopathy. So how is it diagnosed? The child is not able to smile. He has bilateral incomplete eye closure. He gets difficulty sucking, inability to, lack of any facial movement. The first noticeable sign would be a facial diplegia. He has a bilateral facial paralysis, inability to smile, and you can see both eyes, the lateral rectus is paralyzed. The patient has a mask-like face, and when we get an MRI of such a child, it will show absence of seventh nerve in the internal auditory canal. The golden hour syndrome or the auricular vertebral dysplasia. Facial palsy incidence is about 41% in such cases, and the hallmark is a hemifacial microsomia. Another syndrome, Merkel-Rosenthal syndrome, which is characterized by recurrent facial palsy with edema of the lips and a fissured tongue. And we just need to do a conservative management in this case, since the child is getting a recurrent facial palsy and is normal in between. Coming on to the acquired causes, the infectious etiologies, they account for about 12 to 36% of pediatric cases, as compared to about 0.16 to 3.1% in adults, is one of the commonest causes of facial palsy in children. The commonest cause is acute otitis media, though the incidence of facial palsy associated with acute otitis media has gone down because of the availability of so many good antibiotics. Mastoiditis can cause facial nerve palsy. Cholesteatoma, yes. Meningitis. Another very interesting cause is the herpes zoster oticus, which is caused by reactivation of the varicella virus. So it is characterized by painful vesicles in the external auditory canal. Though these may have a delayed appearance. Hearing loss and vestibular dysfunction are not very common in children in herpes zoster oticus. Viral infections like HIV, CMV, EBV, adenovirus, rubella, mumps, influenza, ecovirus, Coxsackie virus, they might cause facial nerve palsy. And remember that 11% of patients, facial nerve palsy may be the first presenting feature of HIV infection. Yes, tuberculosis is very common in the Indian scenario. So any child with facial palsy and purulent ear discharge, always suspect tuberculosis, and after doing a mastectomy, always send the tissue for histopathology to rule out tuberculosis. Acute otitis media. Why does it cause facial palsy? Commonly, it is seen that there is a fallopian canal dehiscence, most commonly in the tympanic segment, and that leads to inflammation of the sheath of the facial nerve. And there is also spread of inflammation along the chora tympani nerve, the stapedius, and the posterior tympanic artery. It is an incomplete palsy, and a wide meningotomy with drainage of pus will definitely relieve the facial nerve palsy. Cholesteatoma, very common. Facial nerve involvement may be seen. It may be because of compression or because of inflammation of the nerve. The treatment lies again doing a modified radical mastectomy or any mastectomy, removing the cholesteatoma and decompressing the nerve, which allows full recovery of the nerve. Infectious causes, a very important cause is a Lyme disease, which is seen in endemic areas. This is a very common disease which is seen very endemic in the United States of America. It is caused by a spirochete, which is called the Borrelia burgdorferi. And facial palsy, it can be unilateral or it can be bilateral. It is due to the invasion of the nerve by the spirochete. And it is transmitted by the bite of an infected Ixox D stick. So characteristic sign is erythema migrans or arthritis, and the drug of choice is doxycycline. Pediatric Bell's palsy, it is not as common as the adult Bell's palsy. So Bell's palsy is, a patient is labeled with Bell's palsy when we cannot find any cause and his hearing is normal and otoscopy is normal. So it is basically a diagnosis of exclusion, whether being adult or a child. The incidence is about 6.1 cases per 100,000 children. It's actually reactivation of herpes simplex within the geniculate ganglion. It is a unilateral low motor neuron facial nerve palsy. And I'll be discussing the management of pediatric Bell's palsy later. About 50% cases have been attributed to Bell's palsy. It is similar to adults, but it has better prognosis and it has an early recovery. So there is a condition which is also called familial facial palsy. What is it? In a study which was done by ADOR, 8% patients with Bell's palsy had a positive family history. So maybe their relations, their mother, sisters, or maybe grandmothers, they all had history of facial palsy. So several reports of multiple episodes of facial palsy with a family history of Bell's palsy patient is labeled as having a case of familial facial palsy. These cases often have early age of onset, they are recurrent, and they have a very good prognosis. Neoplasms causing facial palsy, one of the very commonest neoplasm, which is in fact misdiagnosed as chronic otitis media, is rhabdomyosarcoma of the temporal bone. So any child presenting to you with facial palsy with an oral polyp, hearing loss, always take a biopsy first to rule out rhabdomyosarcoma. Then histiocytosis, another malignancy causing facial palsy, then tumors like schwannomas and hemangiomas of the seventh nerve. Tumors of the parotid gland, which are not very rare in the pediatric population, they're also a cause of facial nerve palsy. Leukemic infiltrates of the temporal bone, they can lead to a bilateral facial nerve palsy. Trauma, as in adults, it can be blunt or penetrating trauma or iatrogenic trauma. So penetrating or blunt trauma, it can lead to a temporal bone fracture and thereby causing facial palsy. So you all know temporal bone fractures are of two types. They can be longitudinal or transverse. And transverse fractures are more commonly associated with facial involvement. Now the newer classification is of the otic capsule violating and otic capsule sparing. So facial nerve palsy is more commonly seen when otic capsule violating fractures. Yes, iatrogenic trauma, we have to be very careful to avoid facial nerve injury in children. There are a lot of surgeries which we can traumatize the facial nerve. So the most common being the ear surgery. The children are at higher risk of facial palsy because during mastoid surgery, it's because I've already discussed earlier, this because of the acute angulation of the second genu and as it lies lateral. So another is the tympanic segment being dehiscent gets traumatized. The presence of a low-lying tegmen or granulations in the middle layer or bone erosion due to cholestoma also puts the facial nerve at risk. In oral atresia or stenosis, since the patient already has an anomaly, the facial nerve course can be anomalous. So always be cautious in those cases. The nerve lies lateral to the annulus in the vertical segment, so you may encounter the nerve very early. Facial nerve palsy has been an important complication of cochlear implantation. So because we are doing implants in fact anomalous ears also, the facial nerve course may be anomalous. So always have a good look at the MRI and the CT scan to know about the inner ear anomaly and the associated facial nerve anomaly so that you can modify your surgery. Another, the iatrogenic parotid surgeries when it's being done in kids, so the facial nerve lies very superficial. So what technique one technique has been advocated by Farrier et al. To identify the facial nerve. So we look for the facial nerve in a triangle which is bounded by the sternocleidomastoid, the digastric, and the external auditory canal. So you look for the facial nerve in this triangle. Since the facial nerve in children, it lies in a very superficial region. So it is safer to look for the facial nerve in this triangle. And always try to preserve the parotid skin and the facial nerve while dealing with pathology of the intraparotid lymph nodes. So whenever we're dealing with intraparotid lymph nodes, always try to preserve the parotid skin. Branchial cleft anomalies, we all know branchial cleft because it is the facial nerve is a branch of or it is the nerve of the second branchial arch or the hyoid arch. So whatever branchial cleft anomalies first or the first branchial cleft anomalies, so they have a close relationship with the facial nerve. So the branchial cleft sinuses, they lie superficial to the facial nerve, whereas fistulas, they lie deep to the facial nerve. So as the facial nerve, it courses over the fistulous tract, it can lie more inferior than usual. So always try and identify the facial nerve whenever you are dissecting a fistula to avoid from causing injury to the facial nerve. Coming on to rare causes of facial nerve, one, children hypertension. Hypertension is a very important cause which is quite often overlooked, and it can cause misdiagnosis, can in fact lead to disastrous consequences, because if a child has hypertension and we treat him as a case of Bell's palsy and prescribe corticosteroids, so that would lead to a hypertensive crisis. So always check the blood pressure of a child with facial palsy. Then SLE, systemic lupus erythematosus, sarcoidosis. Granulomatosis polyangiitis, also called Wegener's granulomatosis. So it's a classical triad of vasculitis, necrosis, and granulomatous inflammation of the upper and the lower respiratory tract. So diagnosis is made by doing an ESR, a C-ANCA, and histopathology. So management again includes corticosteroids and chlorpromazine and cyclophosphamide. How does facial palsy in a child present? So sometimes because of a good facial tone, you're not able to make out the facial palsy at rest. In neonates and small children, only when the child cries, there is deviation of the angle of the mouth, or there could be asymmetry at rest. The child may not able, a small child may not be able to suckle. The eyes does not close. There could be epiphora. Speech is not clear. The patient is not able to whistle. He won't be able to blow a balloon. He will complain of pain or paresthesias of the pinna, and some children also complain of change in the taste, like complain of a metallic taste. So how do you diagnose, or how do you come to a diagnosis? Firstly, a detailed history taking about the onset. If it is sudden onset within hours, then it could be Bell's palsy. If it is a more gradual onset, it could be some otitis media, or it could be cholesteatoma causing a facial palsy. Then duration, what is the timing, how much has been the time of the onset of the facial palsy? Any history of pain in the face or behind the ear? Is it progressing or is it improving? Gradual onset with progression over 3 weeks is suggestive of malignancy. Any history of ear discharge? Any history of facial palsy? Any comorbidities? Or any other anomalies in the head and neck and the cranial nerves? There are some red flags. You have to be very cautious and do not label these cases as Bell's palsy. Child having severe headache, blurred vision or double vision, weakness, numbness in the arms, extremities, ataxia or stroke, hyperacusis and altered taste, they are uncommon in Bell's palsy. Severe pain is suggestive of varicella zoster Ramsay Hunt syndrome or mastoiditis, and recurrent palsy could be suggestive of malignancy or any systemic disease. When you examine a patient of Bell's palsy, always examine the external auditory canal for vesicles. Look for mastoid tenderness. Examine the tympanic membrane. Look for erythema, any polyontoria, presence of cholesteatoma. See the eye to look for any corneal ulcerations, skin lesions for vesicles, signs of malignancy, any leukemia, pallor, hepatosplenomegaly, and always check the blood pressure. High blood pressure can also cause recurrent facial palsy. And do a House-Brackman grading. So House-Brackman grading is the same what is for adults. So grade 1 is normal symmetrical function in all areas. Grade 2, when you have slight weakness, which is noticeable only on close inspection, there is complete eye closure with minimal effort. Grade 3, when there is complete eye closure and strong with maximal effort, and but there is no disfiguring synkinesis or mass movement or spasm. Grade 4 is when there is incomplete eye closure, in fact, with maximal effort, and there is asymmetry of mouth with maximal effort. Patient will have severe synkinesis. Grade 5, when motion is barely perceptible, there is incomplete eye closure. There is only slight movement at the corner of the mouth. Grade 6 is no movement. There is loss of tone, no synkinesis, contracture or spasm. Evaluation. How do we evaluate? Audiological evaluation. First, the pedal reflex to localize the site of the lesion. Get a complete blood count. If you are suspecting meningitis, child has headache, fever, do a LP or lumbar puncture. For viral diseases, ELISA for IgG and IgM. Serological test for Lyme disease, if history of possible exposure. CRP, ESR, ANCA, if you are suspecting other inflammatory disorders. CT and MRI are done if there is a suspicion of chronic otitis media, acute mastoiditis, trauma to temporal bone, a neoplastic etiology, or there is recurrent facial palsy, or if the facial palsy is not improving beyond 3 weeks. So there are certain indications of doing CT and MRI. So when we do an MRI, we see the entire facial nerve from the pons to the parotid gland. Electrophysiological tests have not been recommended in children to identify the cause, but they can be done to identify the cause of paralysis and define prognosis and predict recovery. If there is no recovery by 6 weeks, if you see the patient child is not recovering, then you rethink the diagnosis. The American Academy of Otolaryngology Head and Neck Surgery Federation advocates that routine lab investigations are not required for patients presenting with Bell's palsy and recommends electrodiagnostic tests only for complete paralysis. So this is an algorithm for diagnosis of facial palsy in children. Once you examine, you see that forehead muscles are affected by palsy. If they are not affected by palsy, then probably it could be a central lesion. Immediately do an MRI and do a stroke evaluation. If the forehead muscles are involved, it is a peripheral facial nerve palsy. If at birth, consider traumatic or any syndromic causes. If not at birth, after birth, it could be trauma. Ask a history of trauma. Yes, if it is there, consider a temporal bone imaging. If there is no history of trauma, then it could be otitis media. Look for vesicular lesions or any other secondary causes. Yes, if there is there, then you use a suitable antibiotic, an antiviral agent, or any other treatment. If there is no otitis media, no vesicular lesions, and the child is having recurrent attacks with facial swelling and fissure tongue or any red flags, then yes, consider Merkel-Cell, Rosenthal syndrome, or malignancy. If no such history and examination is clear, then possibly it could be Bell's palsy. You would consider steroid treatment, eye care, and physical rehabilitation. Now coming on to the management part. Management of Bell's palsy, as in adults, we have been using steroids with good results. Childhood idiopathic facial palsy, it recovers spontaneously. So there have been a number of studies and there is lack of, in fact, controlled trials about the use of corticosteroids in children in Bell's palsy. There are some studies which like J.A. McCall, and they say that use of steroids can be used to minimize the sequelae of facial palsy. But these have to be started within 3 days of onset of symptoms. Though many studies found no difference, the only role of steroids is to hasten recovery, to reduce the sequelae, and to minimize the incomplete resolution. In case of herpes zoster oticus or Ramsay-Hunt syndrome, is to be treated as early as possible. So intravenous steroids with antivirals in children older than 2 years. More than 2 years, you can give acyclovir 80 mg per kilogram per day, 6 hourly for 5 days. And more than 12 years, it can be valcyclovir 20 mg per kilogram 3 times a day to a maximum of 1000 milligrams. Acute otitis media, antibiotics, IV antibiotics, and a wide meningotomy to drain the pus. In case it is mastoiditis, you have to go in for a mastodectomy and a meningotomy. What about the surgical management? So the surgical management, the primary goal is to re-establish the continuity of the facial nerve. So how can we do it? We can do it with a direct neuroraphy, or we can use nerve graft, nerve transfer, nerve crossover, muscle transposition, or a free muscle transfer. So I'll make things clear for you. So what is the function of a nerve grafting or a repair? So let us first understand primary neuroraphy and grafting. It can restore the involuntary expression because the supply is from the facial nucleus. So in case the duration of injury is less than 1.5 to 2 years, that is 18 to 24 months, we can think of nerve grafting or repair. But for that, we should have a knowledge that the function of the muscle is there. So what we need to do is electrodiagnostic test for that. So EMG is done, which determines the function of the muscle. So for primary repair or grafting, we also need an intact facial nerve trunk and a functioning facial musculature. When a portion of the nerve gets disrupted, then we can use a cable graft. So what is used as a cable graft? The most commonly available nerves, the greater auricular and the sural nerve. These are two nerves which are commonly used as cable graft, and we can use this graft between the distal end of the disrupted facial nerve and the proximal end, the proximal end of the disrupted and the distal end of the facial nerve. So in this case, the EMG and the electroneurography are valuable tools in estimating the reversibility of paralysis. EMG, the electromyography, is used to exclude irreversible atrophy, which takes about 18 months. And ENOG, it predicts the synkinesis, which is typically 12 months later. So if there is lack of clinical and electrophysiological recovery within 6 months, there is no recovery. We've been doing electromyography and electroneuronography, and we see there is no recovery within 6 months, then re-innervation surgery can be taken up before total muscle and motor unit atrophy. So why do we need to do it? So what is the need of facial reanimation? The ultimate goal is to provide eye closure, oral competence, facial symmetry, and involuntary movement. And it is done when there is no likelihood of spontaneous return of function in cases like congenital facial palsy. So these are the procedures: nerve grafting, repair. We've already talked about this. So what are the nerve grafts? So the commonly used is a hypoglossal to facial anastomosis. It is an end-to-end or it is an interposition graft. The hypoglossal nerve, it is isolated in the neck and it is split longitudinally into two. So it is split longitudinally into two, and one of the superior portion is then anastomosed with the distal portion of the facial nerve. So this helps in retaining the muscular activity of the tongue. So this has been a very commonly used anastomosis and gives good results. In case there is no functional neuromuscular unit, then there is we can use a transposition of free, that is gracialis, or a pedicled muscle, that is a temporalis muscle. Free muscle transfer with neurovascular anastomosis is the mainstay of treatment in children with congenital disorders. So this is a dynamic technique which allows the patient to have a voluntary smile. Static techniques include facial atta slings and Gottes. So let us understand what is the importance of static versions and what is dynamic techniques allows the patient to have voluntary activity like a voluntary blink reflex, involuntary activity like a blink reflex or a emotional smile. Whereas static versions, they just elevate the skin, the muscle, they just avoid the laxity of the face, and it gives a more symmetrical appearance at rest. Ocular rehabilitation. The paralysis of the orbicularis oculi muscle, it results in a bad eye syndrome. So what is this bad eye syndrome? Bad eye syndrome is corneal anesthesia, a dry eye, and the absence of Bell's phenomena. So in case the patient has this would lead to corneal abrasions, keratitis, and irreversible blinding. So we need to prevent it by doing ocular rehabilitation. It can be done by giving artificial tears during the day and an ophthalmic ointment with eyelid patching at night. The surgical technique which has been adopted for ocular rehabilitation, it could be static or it could be dynamic. Lagophthalmus can be managed with static eyelid procedures to assist the upper eyelid closure, or we use eyelid weights or a palpebral spring. Most commonly, eyelid weights which are used are of titanium because these do not form a capsule and they can be removed in case the patient recovers. So the procedure involves an incision in the supratarsal crease, and there is dissection between the orbicularis oculi and the tarsal plate, and a small weight is kept which helps in the movement of that helps in passively closing the upper eyelid. So this procedure can be performed under local anesthesia in cooperative children. Lower eyelid malposition is less commonly seen in the pediatric population. The procedure done for this is a lateral canthotomy. We call it as a tarsal strip procedure. a lateral canthotomy followed by cantholysis, creating a tarsal strip and attaching this tarsal strip to the superolateral portion of the orbital rim. So this will tighten up the lower eyelid and it helps in the management of the lower eyelid. How do we get the blink reflex back? So blink reflex, for this dynamic techniques are required to restore the blink reflex. Nerve can be transferred and eye sphincter substitution can be done. The nerve transfer, it includes a cross-face nerve transfer, the mini hypoglossal nerve transfers, and direct orbicular oculi neurotization. So what is this neurotization? So neurotization and interposition graft is co-opted between the unaffected facial nerve and it is cut into fascicles. It is divided into fascicles, and these fascicles then they are made to implanted into the epimysium of the upper and the lower orbicularis oculi. So this is direct neurotization of the orbicularis oculi muscle on the opposite side. The frontalis branch and the frontalis muscle can also be used, like in this figure. There is a nerve, a graft has been used between the unaffected nerve on the opposite side, and this sural nerve or the greater auricular nerve is then anastomosed, and the frontal muscle with the frontal muscle, frontalis muscle, and this frontalis muscle is being placed in the orbicularis oculi region. So this also gives a spontaneous blink reflex. Nasal rehabilitation. So because of the laxity of the facial musculature, there is an external nasal valve collapse and nasolabial fold anomalies. So deviated nasal base, it can be corrected with the fascia lata sling. The fascia lata sling, it is harvested from the lateral thigh, and then after making a parotidiectomy incision, this sling is transposed, it is kept in the subcutaneous tissues from the preauricular crease up to the ala, and then it is, you can see the preauricular, the region, superior region, it is attached to the temporalis fascia, and this is the area where it is attached to the tissues in the ala, and then it is stood. So this helps in elevating the nasal labial fold and the ala, and thereby avoiding nasal valve collapse. Smile rehabilitation, it is for a static procedure. You can just use a facial lata skin, which is a static procedure. It will just elevate it, but there'll be no voluntary or emotional smile. So dynamic rehabilitation, it can be accomplished with muscle flaps or free regional muscle flaps or free muscle flaps. So regional muscle flaps, they include the temporalis muscle. So this temporalis muscle is the tip of the coronoid process. It is removed from the tip of the coronoid process, and then it can be divided into fascicles and it can be inserted into the orbicularis oris muscle. The other dynamic flap is the gracialis muscle flap. So this is the first line treatment for healthy pediatric patients who desire a dynamic smile reanimation because of its lower donor site morbidity and ability for the simultaneous harvest. So in this, it is done in two stages. First, the cable graft, whether the sural nerve or the greater auricular nerve, it is harvested, and then it is placed between the contralateral, the normal side nerve, and in the upper buccal sulcus. So it is inserted, it is a parotidiectomy incision is made, the nerve is identified, and the nerve is anastomosed with the opposite normal nerve, and it is kept in the upper buccal sulcus. 6 to 9 months later, the gracialis muscle is harvested from the thigh, and along with its the nerve and the obturator nerve and the adductor artery, and this is then the nerve is anastomosed with the cable graft, and the vessels are anastomosed with the facial vessels. So this gracialis muscle is then attached to the temporal fascia and the orbicularis oris muscle. So this gives a dynamic smile. This is the dynamic procedure, gives a dynamic smile. The only problem with this is that it has two nerve anastomosis. So the outcomes are, there are all chances that it could fail because there are two nerve anastomosis. The nerve has to grow along these two anastomosis. Another thing what can be done is a masseteric nerve innervation to the smile nerves or to the facial nerve. The only problem being that it is not a dynamic procedure, and it will not be giving an emotional, spontaneous smile. The smile rehabilitation for the lower lip. So the lower lip, the paralysis of the depressor labii inferioris, it results in a superiorly malpositioned lower lip and asymmetry, which is worse while speaking as well. This is more commonly in the asymmetric crying faces children. This is done. So there are static as well as dynamic therapies for correcting the asymmetries. The commonly used procedure is the contralateral lifting. The contralateral portion is also weakened by weakening by chemodenervation of the opposite depressor anguli oris using botulinum toxin. And if it is successful, then permanent weakening can be done by a transoral resection of the depressor labii inferioris fibers under local anesthesia. It has very high success rates. There have been other options like the wedge resection. So this portion is complete wedge resection is done and then it is sutured and you can see the elevation of the lip, or it could be a kiloplasty can also be done. Another procedure is the transposition of the posterior belly of the digastric. So this digastric muscle belly, it is removed from the hyoid bone and from the mastoid, and then it is inserted into the lower lip, orbicularis oris. One very disabling symptom of the recovery of facial nerve is synkinesis, whether it being the recovery after Bell's palsy or Ramsay Hunt or other is synkinesis. So it is defined as an aberrant axonal regeneration resulting in involuntary muscle movement on voluntary muscle contraction. If the child tries to close his eyes, maybe the angle of the mouth also lifts up. So this is very common after facial paralysis. The treatment, it can be non-surgical in the form of physical therapy and Botox injection. So physical therapy includes massage, neuromuscular training. Surgical procedures like cross-facial nerve grafting and secondary micro-cooptations serve to break the synkinesis cycle have also been adopted. There have been certain regenerative therapies which has been like direct neural interface for a smile, and different types of stem cells have been produced for embryonic, nerve, mesenchymal adipose and bone marrow derived stem cells have been produced for the regeneration of the nerves, but those are still under experimental, they're undergoing experimental, undergoing experiments, and like bioscaffolds also for the support to the facial nerve. So coming on to the prognosis of facial nerve palsy, it is correlated to the severity of palsy and the timing of presentation. The perinatal forms, they recover by 4 months of life. Bell's palsy usually has good prognosis, and Ramsay Hunt has worse prognosis as compared to Bell's palsy. Only 10% patients recover fully. And the sequelae are commonly seen with Ramsay Hunt include contractures, spasms, and synkinesis. So, what is of utmost importance is in case of a child presenting with facial palsy is early diagnosis and management. So, if because this facial palsy it leaves is seen on the child's face and leaves a very long-lasting psychosocial impact. So, early diagnosis and management of facial palsy is of utmost importance. So this is all about facial palsy. I know it's a huge topic which cannot be completed in 1 hour because so this is what is the overview of what you need to know about facial palsy in clinical practice. So thank you for your patient listening. Thank you for your patient listening. Um,
Ma'am, there are few query in the chat, ma'am. There is one query, ma'am.
yeah, I'm just coming to that.
Let us scroll down the chat box, ma'am.
Yeah, just a minute. Somebody's asked me, please show the starting slides. How do we suture nerves? So one, yes, very pertinent question. How do we suture nerves? So, nerve, when we are doing an anastomosis, in case you have traumatized the nerve, or in case you're doing a fresh anastomosis, we always, the facial nerve is cut obliquely. So we give a cut obliquely to the facial nerve because we want to increase the surface area of the number of the axons available. And when we suture it with a nerve graft, suppose you're doing it in the temporal bone, when you're doing a mastodectomy and you've disrupted the facial nerve, we can just keep the graft close to the facial nerve and then just envelop it with a temporalis fascia or perichondrium, so that the nerves, they grow, they reach the two cut ends of the nerve, they are in close, they abut each other, and the axons, they grow into the neural tubes. In case, because suturing within the temporal bone becomes very difficult. Otherwise, what you can do is you can give 9-0 or 10-0 sutures. When you are doing an extratemporal suturing, a 9-0 or 10-0 suture you can do to the perineurium. You separate the epineurium, you can do a perineural suturing. So the best is to envelop it in the perichondrium or the temporalis fascia in the temporal bone. If it is outside, then you can suture the epineurium and give 3 sutures. So minimum number of sutures, if the try giving minimum number of sutures, because otherwise the number of sutures you give, you may traumatize the nerve. So minimum number of sutures are enough for it. Yes, another question is, children bilateral facial palsy is common or unilateral? So commonly it is unilateral facial palsy. Most common is Bell's palsy, what you see in children, or facial palsy, which is secondary to acute otitis media. So these are two causes. Bilateral facial palsy is seen commonly in children, like in, you can see in hypertension or with syndromic children. Bilateral is common. So otherwise, what commonly in the clinical scenario, what we see is of unilateral facial palsy. In fact, in our Indian scenario, children come to us with long-standing ear discharges and being neglected for, they have never visited an ENT surgeon. And when you peep into the ears, they are having cholestoma. So cholestoma is another very common cause of facial palsy in the Indian scenario. So I think these are the questions. And yes, so role and dose of steroids in post-op facial palsy. Facial palsy cases post-op steroid. You are Dr. Gaurav. He wants to know the dose of steroids in post-op facial palsy. Um, Post-op facial palsy, it depends on, first of all, you need to decide whether you have traumatized the facial nerve or not. If the surgeon has operated and he knows, he's confident that he has not traumatized the facial nerve, yes, then you can give him post-operative steroids and it is delayed palsy. But in case you have traumatized the facial nerve, then there is no fun of giving post-op steroids. In case you have completely disrupted the facial nerve, the dose of steroids is the same as in Bell's palsy, that is 1 milligram per kilogram body weight, and to be continued for 7 days. And in case it is relieved, then you can taper the doses. But in case you have traumatized more than 50% of the facial nerve during surgery, then you need to explore, open and see where you have traumatized, and you can do a nerve grafting. So in Rosenthal syndrome, whether it's recurrent facial palsy on same side or both sides, so it can be on either side. So it can be on either side, Rosenthal syndrome. It can be recurrent facial palsy on either side. It can be on the same side also. It has been seen on the opposite side also. Similar with Bell's palsy also. So Bell's palsy and familial Bell's palsy, they can be recurrence on the same side or on the opposite side also. So So the thing which distinguishes it from Bell's palsy is fissured tongue and edema of the lips also associated with it. So these are the questions. I think I've answered all of them. So somebody asked about EMG and electroneurography. Electromyography is basically used to see the muscle atrophy. In case the muscle is atrophied, if there are no potentials in it, no motor action potentials, that means the muscle is atrophied and there is no use of doing nerve grafting. So what you need in this is a muscle transfer, of a free or a pedicled muscle transfer. Electroneuronography is basically done to evaluate whether there'll be a recovery or not. So fibrillation potentials can be seen. So this is electroneuronography for that. So this predicts recovery. If the patient will be coming out, the patient will be recover or not. So it diagnoses the fibrillation potentials. So this is a huge topic. It is to be this is an individual topic to be covered. So I think all the queries have been answered.
Thank you, ma'am. Thank you all attendees for joining this session.